I just wanted to remind you, so we were mentioning this in these very rare cases in which you could have empty follicles. So what you do actually is, what I do is, and I did this several times, you empty one side, and if you have the impression that this is empty, all of these follicles are empty, you just stop your retrieval. You re-trigger with HCG, and you see the patient 34 hours later, and you do pick up on the left side, the side which was still left. So you'd actually, you lose follicles from one side, but you do not lose the cycle. And we did this several times. We even transferred fresh in these patients and have ongoing pregnancies. So just to remind you, don't just keep on doing the pickup. Stop, re-trigger, and see her again after 34 hours. Okay, so now I was asked to talk a little bit about the new Humaidan stratification. So I'd like to mention a little bit about the Escher-Bologna criteria, looking into these new Humaidan criteria for poor, and we will give an overview of clinical management also. When we talk about defining the poor responder patient, everything is just about agreeing about a definition over the years. Recently, this paper came out from Brussels, in which our colleagues were asking the question, for the poor responder patient, is there actually any light at the end of the tunnel? So what they did a systematic review of all trials using the term poor variant responder. And what you can see they found was 49 randomized control trials using 41 different definitions of poor. Imagine, and even some groups who did more RCTs would use different definitions from trial to trial. And on the right-hand side, you can see the definitions used to define a poor responder patient. It could be age, previous trials, AFC, FSH consumption, etc., etc. Now, for you, for me, and the patient, the only thing which actually matters is the number of preoperative follicles and the number of oocytes that you got, obviously. So, then in 2011, we had the Escher-Bologna criteria. And just to remind you, you need two of the following three features to be present to be a Bologna poor. Either advanced maternal age, that is above or equal to 40 years, or any other risk factor for poor, which could be surgery, it could be chemotherapy, or you needed to have had a previous poor, which means less than or equal to 3 oocytes with a conventional stimulation protocol. So what is a conventional stimulation protocol? Well, it's between 150 to 225. And finally, if a patient had an abnormal ovarian reserve test, that is an antral follicle count less than 5 to 7, or MH less than 0.5 to 1.5, this is then one of these three criteria to be fulfilled. However, if you had 2 previous episodes of less than or equal to 3 eggs after maximal stimulation, per definition, you are Bologna poor. And what is maximal stimulation? This is 300 units of FSH. Now, I think we can all see that how can you have criteria in which there is a range of less than 5 to 7 and less than 0.5 to 1.1? This is difficult. Why didn't they agree just on one fixed criteria? However, they didn't, and this was as good as it was in 2011. I think we were all happy when we were presented with these criteria. But we have to ask ourselves, are these criteria actually fulfilling? Because Bologna poor are presented as a single group of patients, but they're not. They're a heterogeneous group of patients. Because there is a real confusion between poor ovarian reserve and poor response. Just to give you an example, you can have this P2S lady that you treated with a very low dose of FSH because you were afraid of her OHSS. She has an excellent ovarian reserve, but she ends up as a poor responder due to wrong FSH dosing, and she fits in the Bologna criteria. So this is a Bologna criteria patient, although we all know that for the next cycle, we would improve her outcome significantly just by increasing the FSH. And again, Bologna is more like a mathematical model it doesn't take age into consideration. So young patients and old patients are compiled in the same big soup, because you remember you needed 2 out of 3 criteria to be fulfilled, and one of these criteria was age, but just 2 out of 3 criteria needed to be fulfilled. And obviously age plays a significant role for outcomes. And again, no clinical recommendations. Okay, this is the patient, that's it. So what are we supposed to do? Just to go into this idea about reserve and response, you can see on the upper panel this wonderful PCOS lady who was maltreated because we were afraid. I mean, we see this on a weekly basis, all of us. We were afraid. Or maybe she had an FSH receptor resistance, which a lot of these PCOS ladies have. So when we start off with 2 low doses, we end up with nothing. So this lady gave us 30% of her follicles, and this is a poor response. In the lower panel, you see a lady with a poor reserve, but she gave us 70%, and we can actually not ask for anything more. So she is a good responder with a poor reserve. So you could say, well, we were so happy with the Bologna report, I feel quite confused. What's the idea about this? Well, the idea obviously is the live birth rate. And this is a trial from Brussels, a retrospective analysis of a quite nice large number of studies in which the fresh and frozen cycles were accumulated for patients according to the number of oocytes that were retrieved during pickup. You can see there were like 4 groups, A, B, C, D. So they had a poor group, less than 3 eggs. Then they had a suboptimal group, 4 to 9 eggs. They had an optimal group, 10 to 15 eggs, and they had a hyper-responding group, more than 15 eggs. And then they correlated the live birth rate. And what you see, obviously, is the number of eggs retrieved, but also the live birth rate for the fresh cycle. Now, interestingly, there is no significant difference in the fresh transfer live birth rate between groups B, C, and D, that is the suboptimal, the optimal, and the hyper-responding. But obviously, the group A comes out with a significantly lower live birth rate because there are fewer eggs to select between. So this is for the fresh cycle. But if we look for the cumulative, which we tend to do more and more, because our freezing programs are very well functioning, you can see again there is a significant difference now in cumulative live birth rates by all groups, in which even the suboptimal perform at a lower rate. So just telling us again that we should be in the range of 10 to 15 to have a nice cumulative live birth rate. If we go above 15, we have the risk of OHSS, but again, as Elias was saying, well, if there's too high a risk, we can always use an agonist trigger and there will be no risk of OHSS. So, I mentioned that Bologna does not take age into consideration. Now, look at age and oocyte yield, a large data set from Brazil. Obviously, there is a steep decline in the oocyte yield from the age of 34 and onwards. So this is oocyte yield. So what about quality? Well, obviously age also plays a significant role for quality in terms of impaired mitochondrial function, so less energy for cleavage and for implantation and for function, increased granulosa cell apoptosis, so poorer quality of the oocytes due to poorer quality of the granulosa cells. Now we know that this can actually be reduced by adding LH, because LH has a positive effect reducing granulosa cell apoptosis. Moreover, we also know that the oxidative stress is increased in the aging oocyte. So a lot of impacts on oocyte quality. Now, with quality, you will also have changes in euploidy. Now, a large data set from Hamburg, 4,600 polar body biopsies, and you can see again a steep decrease from the age of 35 and onwards in oocyte euploidy rate. Now, obviously, the oocyte euploidy rate will impact the euploidy rate of the blastocysts. And look at this, the study by Atta, more than 7,000 embryos, and what we see here is reality. You can see in patients who are less than 35 years, in this huge data set, 40% of blastocysts, not embryos, blastocysts were abnormal. So 60% were euploid. And if we go to the aging patient group, let's say more than 42, you just have 10 or 15% normal blastocysts in these patients. And for the 40 to 42-year-old lady, around 25 to 30% normal blastocysts. So this tells us why we run into these difficulties that we do with the aging population, because this is nothing which can be changed with pharmaceutical drugs. So, some years ago it was suggested that stimulation has a negative impact on euploidy, but is this true? No, it's not. This is very, very nicely shown. You can see to the left you have the young oocyte donor, and then you have patients. What you see is that regardless of the number of embryos these patients produce, 1 to 5, 5 to 7, more than 10, the euploidy rate is completely constant. What you can see is that the euploidy rate changes by age. So in a lady who is less than 35 years of age, it's 38% normal, and then when you go to the ladies above 42, it's just 5% normal embryos. Telling you, regardless of stimulation, regardless of how many embryos, that stimulation does not increase aneuploidy. In contrast, obviously, the more embryos, blastocysts we have in an older patient, the higher the chance of being able to transfer just one good blastocyst. But we need a lot of blastocysts to find this one euploid blastocyst in the aging, for the aging population. So, again, this is from the Sonkara paper, 400,000 cycles. What we see is that in the low-range oocyte group, one more oocyte makes a significant, or rather a clinical difference, because with one more oocyte, for all these poor responder patients, you actually end up with a more or less 5% higher live birth rate, not pregnancy rate, but live birth rate. So one more oocyte during stimulation makes a significant difference. Just again looking into this proposed idea of a negative impact on of stimulation on aneuploidy rate, an elegant study from EVI, 46 egg donors undergoing either natural cycle or followed by a stimulated cycle. They were using the same donor semen for the same patient, and then they were looking into the euploidy rate. Again, you see there is no difference regardless of the stimulation. So again, stimulation does not increase the aneuploidy rate. Now, taking all these issues into account, specifically the one on age and the idea that you actually compile patients who end up as poor responders because we as clinicians did not do our work the best. We were not aware that they had FSH receptor polymorphisms or variant LH beta presence. We came up with the idea of the so-called Poseidon classification. And you could say, Poseidon, what is this? Well, there is a small island just outside Naples, Ischia. In this island there is like a big thermal place called Poseidon, and we had a meeting there from reproductive endocrinologists from 7 different countries in 2016, in which we came out with this proposition of the Poseidon criteria, and we subsequently published a couple of papers on this. So our idea is to have 4 subgroups based on qualitative and quantitative markers. So the most important, and we heard this also previously today, is obviously age and the expected euploidy rate. We also used the biomarkers AFC and AMH, and if a patient had been stimulated previously, we also take this into account. So our idea is help ourselves, counsel not only ourselves but definitely the patients, and set patient expectations before stimulations, and also try to establish a working plan to reduce time to pregnancy. So our aim is to obtain oocytes needed to be able to transfer at least one euploid blastocyst. Because we as clinicians cannot do anything after the transfer of the blastocyst. This is as good as it gets. For pregnancy, there are so many other factors which will have an impact. But for us, if we can transfer one good blastocyst, which is euploid, we reached our goal. So, this is not complicated. I just want to, you can see we now distinguish between poor reserve patients and good reserve patients. And for the good reserve patients, why did they come up with a poor response? Well, as I told you before, because they were not sufficiently stimulated. They either needed more FSH or they needed the addition of LH. So for the good reserve patients who are Poseidon groups 1 and 2, we obviously need a stimulation, a previous stimulation, to tell us that they belong to this group of patients. They are good reserve. Unexpectedly, they came out with a poor response. And as you can see, we subclassified these patients according to whether they were above 35 or less than 35 years. So young patients, group 1, and we then subdivided into less than 4 eggs and 4 to 9, the suboptimals. And even for the older group, the same. They had an unexpected poor response. They were good reserve patients, and they had either less than 4 or they had 4 to 9 oocytes. So these are groups 1 and 2. Good reserve patients, and you can say, well, we know that they can do better. Yes, we know. Well, they will do excellently well in their next trial, but in the Bologna, they are just in the big soup. Then we get into problems, because now we are in the poor reserve patients. And these are the ones that we would usually consider as poor ovarian responders. But we talk about poor ovarian reserve. We know this prior to stimulation because we can see it when we do our scans. We can see it on the AMH. And again here, we have a young and an old patient, group 3 and group 4. Why? Well, obviously because there's a huge difference in live birth rate between the young patient with a poor ovarian reserve and the old patient with a poor ovarian reserve. So this makes a total of 4 groups. So by doing so, we wanted to avoid the heterogeneity in the Bologna criteria. Now, I just want to come into some ideas of how are we going to stimulate these patients. Well, for the group 1 patient, remember this is the young patient, she's got a good ovarian reserve and she came out with a poor response. Now why was the reason? Well, as I told you, she did not get the correct dose of FSH. Maybe she needed LH, and we definitely know that she needed more FSH. Probably this is a PCOS lady, and you know like me that quite a few of these ladies actually need more LH, although they have quite a lot circulating LH. But once we add the antagonist or the long agonist, we reduce their circulating LH to levels in which folliculogenesis does not occur. So this is why our follicular growth stops, and this is why we need to add LH. Well, we put in brackets, could also be a problem of asynchronous development, but this is rarely seen in this group of patients. But obviously, if they had problems with very asynchronous development, I would suggest if we use antagonist protocol, we would either use OCP or we would use estradiol to synchronize. So this is the idea. They are good reserve, they are good quality patients. We can use the antagonist because we know that we can squeeze these ovaries, and there would be a risk of OHSS. We want to use the antagonist to reduce the OHSS development. We will definitely increase the FSH dose. We would add LH activity, and if we saw this asynchrony, we would use this estradiol and OCP. And for these patients, we would go for fresh transfer if they did not end up in an excessive response. So this is group 1 Poseidon. So group 2 Poseidon. Now they're still good reserve patients, but they are older, so the quality is affected. And for these patients, again, why did we have this low response? Again, the same as for group 1. We had all these follicles, the patient didn't respond, and what can we do about it? Well, again, we know this is a patient we can squeeze more, so we would go for the antagonist protocol. We would increase FSH, we would definitely add LH, because this patient is above 35 years of age, and this has been proven in many trials that you will increase implantation rate in this specific subgroup of patients. You can use HCG, you can use an agonist trigger. Definitely we would go for blastocyst culture. We would let nature select the, let's say, most optimal blastocyst. We are not allowed to do BGS for ethical reasons in my country. And if we had problems with synchronization, we would deal with those prior to stimulation. And for this patient, we would go for a fresh transfer. And if we had an excessive response, obviously, we would go for freeze-all. Yeah, I'm sorry. No, just a few more slides. So let's just move on to the young poor band reserve. This is group 3. She's got a poor reserve, but she's got a good quality. So again, we would go for a long agonist in this patient because usually there is a desynchronization, and we would synchronize either with the long protocol or with the estradiol OCP. We wouldn't stimulate with more than 300 units because this has been proven you don't gain anything. We would, in some of these cases, use what Elias was mentioning. We would do a dual stimulation, so we would stimulate, trigger with agonist, do a luteal stimulation in the same round between 28 days. Well, what about the adjuvants? We don't know a lot about this. And we would either go for fresh transfer or accumulate during more stimulations. And finally, now the worst group of patients, the group 4, poor reserve, poor quality. What can we do? Well, we can just try to do our best. This will be squeezing, and in many cases, these patients will end up in my unit with 2 stimulations at least. Luteal phase, a follicular phase stimulation, agonist trigger, luteal phase stimulation, accumulation, freezing, and transfer, accumulating this number of eggs needed. So, just to conclude, our classification will include an individualized approach in all steps of IVF. This is for the analog regimen, the dose type, and the drug type also, the trigger strategy. And then we, especially for groups 3 and 4, we are using more and more luteal phase stimulation, so 2 stimulations within 28 days. What about adjuvant therapies? Well, there is not evidence for any actually adjuvant therapy. Maybe for testosterone, we need more trials of this. And definitely personalization in lab technologies, trying to push the blastocyst culture. And finally, this will be a new thing, I think, which will be coming up. We will have to check the luteal phase also to know that progesterone levels are there. So thank you very much.